Hello, my name is Christopher, and today we will discuss the clinical approach to the diagnosis and management of primary hyperthyroidism. First, in the prevention, we have to avoid excessive iodine exposure like supplements or contrast agents to prevent triggering hyperthyroidism in susceptible patients. There's also the smoking cessation, which reduces risk and severity of the Graves' disease. Then we have to identify and monitor high-risk individuals like young women or people with an autoimmune background. We also have to educate on early symptoms like palpitations, heat intolerance, or weight loss to promote early consultation. Second, there's the early diagnosis, which is the secondary prevention, and we have to measure TSH as initial screening test in any patient with suggestive symptoms. We have to confirm with free T3 and T4 levels to establish biochemical hyperthyroidism. And then there's the clinical examination of the thyroid, which we will find goiter, tremor, or tachycardia. And then the thyroid antibody testing to confirm an autoimmune etiology, which is, in this case, the Graves' disease. Third, there's the timely treatment, which is immediate management, and we have to start beta blockers like propranolol for rapid control of adrenergic symptoms. And then we have to initiate anti-thyroid drugs like methimazole, which is the first line drug, or in specific cases, the propylthiouracil. Then we have to monitor thyroid function periodically to guide those adjustments. And we have to consider definitive therapy like radioactive iodine or surgery if persistent or severe. Fourth, and finally, there's the rehabilitation plan, which is the long-term management. And there's the regular follow-up of thyroid function to prevent relapse or hypothyroidism. And cardiovascular monitoring, the heart rate, arrhythmias until stabilization, and nutritional recovery to correct weight loss and hypermetabolism. And finally, patient education and adherence to recognize relapse symptoms and maintain treatment. Then there's the follow-up after timely treatment in hyperthyroidism. First, monitor thyroid function with free T4 and TSH every 4 to 6 weeks initially. This will confirm progression toward euthyroidism and guides dose adjustments. TSH may remain suppressed early, so decisions rely mainly on free T4. Second, we have to assess clinical response, especially improvement in tachycardia, tremor, heat intolerance, and anxiety. Symptoms often improve before labs normalize. Persistent symptoms may require adjustment or symptomatic therapy, such as beta blockers. Third, we have to monitor adverse effects, particularly with antithyroid drugs like methimazole. Key complications include agranulocytosis, fever or sore throat, and hepatotoxicity. And then patient education is essential for early detection. Additionally, monitor cardiovascular status, especially persistent tachycardia or arrhythmias like atrial fibrillation due to increased cardiac risk. Overall, follow-up aims to normalize hormone levels, resolve symptoms, detect complications early, and prevent relapse. And that will be everything for today. Thank you for your attention.